I'm hoping that my presentation is going to complement Gavin's rather nicely. Gavin's been talking in the most engaging way about global health policy. I'm going to be getting down and dirty and talking about health service practice. So this is an opportunity to roll up our sleeves and use evidence in a very kind of practical way. Improvement science is what I'm going to be talking about. A science which might be new to many people in this audience. It's certainly new to a lot of practitioners working out there and managers working out there in the service. If I look back over the last 15 or 20 years, I think that the creation of the evidence-based practice movement has been truly remarkable. Prior to the early 90s, I think it's probably fair to say that most of us as practitioners used evidence in a pretty ad hoc way. Since then, the evidence-based practice movement has allowed us to use evidence in a much more systematic, much more accessible way. And I think the consequence has been quite significant, not least in terms of really embedding evidence-based practice into our professional identity as health professionals. But if I had a criticism of it, I'd say that it's still focusing very strongly on clinical practice and not on the organisation and delivery of care. And that, to me, is a major challenge because there are significant deficiencies in the way that care is organised and delivered. Let me give you some figures, many of which you'll be quite familiar with. 10% of patients admitted to hospital suffer iatrogenic harm as a consequence of things that we do to them. The evidence suggests that at least half of that harm could have been prevented if we'd followed simple evidence-based practice. Beth McGlynn's study in 2003 in New England Journal suggested that we implement around about half of the evidence-based processes that we would all agree are good things to do. That figure is an average figure for relatively simple technical things like, say, the management of cataracts. It's possibly 80% of evidence that we put into practice. For the more complex things, like when I'm a GP managing an alcoholic patient, it's about 20% of accepted evidence-based practice. So there's a major gap between what we know we should be doing and what we actually do. And as far as patients are concerned, there's very good evidence that we don't provide the information that patients want. This is just one example from the Commonwealth Fund survey in which a lot of patients have not been told about the side effects of medication despite the fact they specifically wanted that information. So when you look at all that evidence, it begs a very simple question. Why is it that improvement seems to be so difficult? Why is it so difficult to close that gap between what we know we should be doing and what we actually do in practice? I'd like to suggest three possible reasons. The first one, I think, is that we often underestimate the sheer scale of the task. We think the difficult thing is finding out whether drug A is better than drug B. Implementing that evidence into practice is just what we're supposed to do as clinicians, isn't it? It's kind of simple. Often we regard failures to implement as being failures of management, not failures of our professionalism. So there's something about underestimating the sheer scale of the task in front of us. Secondly, it's quite clear that improving care requires a different set of skills, a different set of attitudes, a different knowledge base from just delivering care. Paul Batalden, one of the leaders in the field of quality improvement, says that all of us have two jobs. It's to do our work, and secondly, to be constantly improving how we do our work. It's quite a nice way of describing the challenge in front of us. And knowing how to improve our work can be really quite challenging. When I get out there talking to clinicians in the service, I can see at the extremes two different types of clinicians. Clinicians who get on and do their work in a fairly conventional way, an admirably conventional way, and clinicians who can see the bigger picture in terms of the challenges facing them. So let's look at the difference between these extremes of clinicians. The more traditional approach towards quality would be we deliver the best care we can. And when there are deficiencies in that care, it's not our fault. It's because there isn't enough resources or because we're too busy or whatever. The different approach would be that we're constantly striving to improve the quality of care that we provide. In terms of the focus of attention, most clinicians would focus on clinical effectiveness, perhaps increasingly on safety. But these clinicians with a wider view will focus on all dimensions of quality, and here are the 6 dimensions that the Institute of Medicine would classically describe as being the core dimensions of quality. Traditionally, clinicians will look inwards towards themselves or perhaps towards their own organisation, their own general practice or their own hospital. whereas the orientation of people who think in terms of improvement is much more towards the service user. The focus tends to be on individual patients, or for some people, on populations in the traditional mindset. But in a more progressive mindset, it's about accepting responsibility not just for your patient in front of you, but or not just for your clinic, but for the way in which the whole health system works. Traditional methods of improvement tend to be the ones that we're brought up and trained to deliver, whereas the more progressive approaches will look at any particular approach. Here you can see 4 different categories. The traditional ones are professional approaches that we're all taught about, things like audit, like peer review, like guidelines. But look at the other approaches as well. There's the industrial or organizational approaches, which are hitting healthcare, coming mostly from the industrial sector. Things like business process reengineering, Lean, Six Sigma, PDSA cycles. There's the more centralist approaches, the governmental approaches like regulation or performance management. And there's the more economically orientated approaches like the use of incentives or commissioning or competition. Progressive practitioners seem to want to pick from all of those approaches, not just rely on that left-hand circle. And then finally, the kind of evidence that underpins traditional practice tends to be the hard biomedical evidence, mostly gleaned from randomized controlled trials, whereas the kind of evidence underpinning improvement practitioners is not only that evidence, which is important, but also a lot of the so-called soft evidence from the behavioral sciences. So I think there's significant differences in the way that people think. And perhaps this is nicely described by Albert Einstein, who said, you can't solve a problem by using the thinking that got you there. And too often that's what we tend to do in health services. We see major challenges in front of us every day in our practice, and we solve it using the approaches that we're used to using. Let me give you an example from outside the health sector. In the early 1980s, there was some major starvation amongst children in Vietnam, in North Vietnam, in isolated rural villages. Save the Children were called in, and Save the Children did what these big agencies do very effectively. They raised lots of money in the Western world, they bought lots of food, and they used their remarkable expertise in logistics to get that food out to the villages. A year later, they tried to find out what had actually happened, and the malnutrition rates had not changed one bit. So what they did was approach a guy called Jerry Sternin. And Jerry Sternin was an anthropologist, and they called him in, and he spent 3 months wandering around the villages, just observing, just seeing what was happening. And the first thing he noticed was that in each village, there were not only malnourished children, but also well-nourished children, side by side. So he talked to the mothers of those well-nourished children and said, what are you doing? What's different? And initially they were quite reluctant to talk, and then they opened up. And they said, well, what we're doing is breaking the rules. We're breaking the kind of norms of our culture or our society in 3 ways. First of all, the norm was you feed your child 1 big meal a day. These mothers were feeding them 3 or 4 meals a day. Secondly, when a child has diarrhea, you stop feeding them, you starve them. These mothers said, no, we carry on feeding them. And thirdly, the norm was to eat root vegetables in these villages, and these mothers were taking the green tops of these root vegetables, chopping them up, and putting them into the rice, even though it was generally regarded as not particularly good food. 3 simple things that they were doing for their children, and their children were better nourished as a consequence. So Jerry Sternin got the mothers of the well-nourished children with the mothers of the poorly nourished children, got them having conversations, evaluated the impact of those simple conversations, and 18 months later, the malnutrition rates had reduced by 85%. So just thinking differently can make a major difference to the outcomes that we're trying to achieve, and that's something that we need to be able to do better in healthcare. But the third reason that I think improvement is so difficult is the central message of this presentation, which is I don't think that we have an adequate science to underpin improvement. There is a science out there, but it isn't a science that's particularly well developed, and it isn't a science that is well practiced by most people. Many of you will be familiar with this visual produced by Cooksey. Cooksey described the progression of knowledge from the laboratory, good ideas in the laboratory, up to, at the far end, improving care for patients out there in the service. And he described a number of transition blocks or gaps in that passage of information along the way. We're pretty good at addressing the first gap, not least because there's some good basic sciences that allow us to do it. We're pretty good at addressing the clinical gaps, again because there's good clinical sciences that allow us to do it. But this third gap, which I've described to you, what you might call the improvement gap, or the implementation gap, or the delivery gap, whatever you want to call it, there isn't the same kind of sciences to address it until you start thinking in terms of the potential of the improvement sciences to do that. So let me ask a basic question, which a lot of particularly researchers will ask me when I give this presentation: is improvement really a science? Even some of the leaders in the field, like Don Berwick, a great doyen of quality improvement, says improvement is a goal. He denies the fact that there's a science underpinning improvement. And I hate to criticize him, but I'm not sure he's right at all, because there is a science. And if you look at some of Thomas Kuhn's work on the nature of science, you can see where it fits in. He describes three forms of science: a pre-paradigm science, a normal science, which is a science, an established science, and the so-called revolutionary science, when people start questioning the basic assumptions underlying normal science. It's quite clear to me that improvement science, for a wide range of reasons, sits in this pre-paradigm phase. There isn't a single dominant theory, although there are many theories of change underpinning improvement science. There isn't an agreed definition, although there are several definitions that are available, and I'm going to give you one in a second. And there's generally disagreement over methods. What pre-paradigm sciences do is borrow their methods and borrow their thinking from other sciences. And this is, I think, where improvement science fits in right now. So what is improvement science? In the Health Foundation, we describe it as the application of a range of basic and applied sciences in order to improve the efficiency and effectiveness of efforts to improve healthcare for patients and populations. We think it's got two basic characteristics. One of them is that it's highly applied. It's a science that can only be delivered by researchers working alongside practitioners. So it's very much about making a difference in the front line, but using rigorous scientific methods to do so. And secondly, it's multidisciplinary. It draws on a whole range of disciplines, many of which are described there. So let me give an example of what I would describe as being good improvement science. And I've purposely chosen a paper in a very elitist way from the New England Journal of Medicine, because improvement science is published in top biomedical journals. This is an example authored by Peter Pronovost and colleagues from Michigan, in which he attempted to reduce the infection rates associated with central lines, with central catheters. This is a major, major problem. In the United States, prior to this particular study, there were about 80,000 cases of catheter-related infections a year. Around about 28,000 of those people died every year. And the average cost, excess cost of someone getting an infection was somewhere between $40,000 and $50,000. So enormous implications for the way the health service is delivered. And what Pronovost and his colleagues did was undertook a large-scale improvement project across almost all of the ICUs in Michigan State, but he did so at the same time as conducting a very rigorous evaluation of it. So this was what he called a collaborative cohort, essentially a cohort study, in which he used a range of different interventions to reduce infection rates. The first set of interventions were evidence-based, good evidence-based interventions, all in the literature, mostly technical things: hand washing, full barrier precautions, use of chlorhexidine on the skin, avoiding using the femoral site because you're more likely to get an infection if you put a line through there, and early removal of the line. So simple technical things. But underpinning that, and this is described well in the paper, are a range of broader interactions and interventions that are used. This is part of a wider quality improvement initiative within the particular state that he was operating in. They used checklists, they used data feedback, they used a whole range of kind of social norms and professional peer pressure in order to change practice. So they used a whole range of different methods to improve care. Very pragmatic, but actually really quite rigorous and scientific as well. The end result was incredibly impressive. There was a mean reduction in infection rates from 2.7 infections to 0 infections from baseline to 3 months. And that reduction was maintained initially for the first 18-month period, and then the study continued and was published in the BMJ last year, and continued for a full 3-year period. So a massive reduction, a reduction which in average terms amounted to about a 66% reduction overall on regression analysis. Now, those of you who are interested in improvement and the effectiveness, the effect size of improvement interventions, this is truly remarkable, quite amazing. What was really interesting about this study was, number one, that almost everybody said it's about the checklist. And you might have heard a lot about the checklist. People said it was a checklist what made the difference. They said that very strongly. Secondly, they missed the fact that across the 103 ICUs, there was quite significant variation in the performance. Some of them did really well, some of them did really quite badly. And the third thing that was notable from this project is whilst we knew what the overall effect was, we didn't understand why it had been achieved. So what we saw following this publication in 2006 is lots of different health systems trying to copy the Michigan experiment. We've had an initiative in the UK called Matching Michigan, which has been really fascinating. But what we've seen is the results of those copycats has not been as good as the original study, partly because they didn't understand what was going on. So what Pronovost did was work with a remarkable sociologist called Mary Dixon Woods from Leicester, who's done some really stunning work in this field. And they worked together to try to understand exactly what went on. So they were bringing a social science perspective to a fairly traditional clinical science approach. And what Mary did was analyze this work with a very different kind of head-on. First of all, she said, this is an example, the Matching Michigan example, trying to copy what they did, of what we call cargo cult science. Have you heard of cargo cult science? It's truly fascinating. In the Second World War, in the South Pacific, there were islands that weren't able to get any supplies because the boats were getting torpedoed when they were going to them. So the Americans would have cargo planes which would take supplies to these islands and land on a landing strip and provide for the natives who were living on the island. So it was all going very well until the war stopped, and all of a sudden these supplies stopped as well. And the locals were quite concerned about that because they rather liked having all this food delivered for them. And they couldn't understand why these great silver birds from the sky weren't dropping and giving them food. So what they did was replicate absolutely everything to ensure that the planes came back again. They cut the grass on the runway, they put up lights along the side of the runway, they built a bamboo hut on the end of the runway in which a controller sat. He wore a little hat and he had bamboo things sticking out the top of his hat to act as antennae. They were doing absolutely everything right in order to get the planes to come back again. And of course they didn't, because they'd missed the point. It's an example of cargo cult science, and too often our desire to replicate improvement projects is exactly that. It's cargo cult science. And what Mary demonstrated was a range of different ways in which this intervention really worked in practice, and it wasn't about the checklists. It was about things like peer pressure. It was the importance of social networks, hospitals trying to replicate what other hospitals were doing. It was about the identification of the problem as not being a simple technical problem, how do you reduce infections in central lines, but a social problem. How do doctors and nurses interact with each other? It was about recognizing that a lot of activities that we do are about symbols. They're symbolic activities, not necessarily functional or important ones. And finally, she demonstrated a really interesting balance between soft, coercive ways of persuading clinicians to do things and hard performance management ways, a very delicate balance between the two. So she brought new insights as a social scientist to something which was already a very impressive clinical study. So let me just very quickly finish by summarizing overall the evidence that's available to us as practitioners and as managers and as commissioners in order to improve the care that we're trying to deliver. The evidence will tell us that in order to improve care, you need to bring three things together: effective interventions, motivated people, and a conducive environment or context. And it's only when you bring those three together and focus on improving all three of them that you'll achieve change. In terms of the interventions, we know that the majority of interventions, the Michigan example was an unusual one, the majority of interventions have a very small effect size. Single interventions rarely work, but if you bring multiple interventions together and use them in a synergistic way, you're more likely to get effect. We know that active approaches are better than passive ones, so audit on its own isn't very good, but audit associated with an educational package or financial incentives is much more effective. And we know that interventions are much more effective if they satisfy these criteria. In terms of the environment, we know that most change management programs from Kotter's work fail. Many of us see change management programs, indeed the NHS reforms that we're kind of going through at the moment in a slightly half-hearted fashion are an example of a large-scale change program. About 60% of change programs have no effect whatsoever, and about 10% of them are positively detrimental to an organization. So change programs don't usually work. We know the characteristics of high-performing organizations, and we know the characteristics of failing organizations. And we know that all interventions have unintended consequences, and usually the more effective the intervention, the greater the unintended consequence. But those consequences can be predicted, and largely they can be managed. And we know an awful lot about how to motivate people, that different people can be motivated by different things in very different ways. They're at different stages of their understanding of the change cycle. But we don't tend to use this evidence in any way that's particularly sophisticated or particularly useful in the front line of the service. So what next? I think we need to really build and encourage and promote the use of improvement science. There is a scientific thinking which is complementary to the basic sciences and the clinical sciences, and we need to really build on that. We need to build the capacity and capability of improvement science, and the Health Foundation is investing in a series of postdoctoral fellowships right now. We've just started our first cohort. We're about to start a series of doctoral fellowships as well, in order to really get people into this field of improvement science. We need to get funders into this area, funding more work like the Michigan study and other examples which are very good. And we need to identify what the key challenges are, and I've put some here, some around context, some around spreading change, some around understanding the interaction of interventions. So there's lots of challenges open to us, but here I think is a science that is ripe for development. Thank you very much for listening.
Thanks, Professor, for such a great talk. It's a pleasure listening to you. I come from Dubai. We've seen improvement in a lot of areas, but not necessarily healthcare. And I wonder how much can we learn from the other industries, especially the aviation industry. There's a YouTube video, and I would like the audience to see it if they have the time. It's called, "What if the airline industry would function like the healthcare industry?"
Yeah.
Your comments, please.
And there's another book, which is "What if your hospital was run by Disney?" which is actually, despite the horrible title, is actually a really fascinating book. There is an awful lot, I think, that we can learn from other industries in terms of innovation and in terms of improvement. And I think the airline industry and the nuclear industry in particular have had a major impact on a lot of work around safety in health systems. So there is a lot. I think we do need to be careful about taking the analogies too far, and some people have done. And certainly the aviation industry has got a bit of a bad name in the safety world at the moment in healthcare, because some of the suggestions that they were making didn't seem to be particularly applicable. But I've got no doubt that there is a lot of learning that could be done. And there was a great study a great paper in BMJ Quality and Safety, published about 2 months ago, by Carl McRae from Leicester, looking precisely at what lessons can be learned from the airline industry. So well worth a read.
Interesting, just comment on that is, I'm actually in the middle of an MBA, and there's a subject called operational management, which is all about managing operations. And you define most things that are offered into either a product or a service. Products are easy to commoditize, they're easy to deliver at volume, and they're even easier if there's very little variety involved. Whereas healthcare is actually a service, there's an expectation of customization around the individual, and there's quite a lot of variety. The difference is that healthcare not only has a very high level of variety attached to it, it also has a volume driver as well, so you've got both of those. So actually, when you apply a conceptual framework that actually recognizes what's different, I think, which is what Martin's saying about taking the analogy too far, you reckon there really are tensions. I'm not sure you would want McDonald's medicine necessarily. So,
Peter McCulloch from Oxford. Martin, first of all, I'm really glad to hear you on behalf of the Health Foundation saying Don Berwick is wrong, and that we need a science of quality improvement. Secondly, just to reflect on our own experiences in our quality and safety intervention studies at the moment, we're finding repeatedly that we can engage very well with clinical staff, and we can engage very well with top management, but motivating middle management in hospitals to get into quality improvement is exceedingly difficult, because all their drivers are just about keeping the machine going. Yeah. And anything that diverges from that for a fraction of a moment is regarded as unnecessary, unwanted, and undesirable. And I just wondered if that reflection resonated with you, and whether you had any helpful advice for us.
Yes, it does, and no, I don't. Is the quick answer. It is a major problem, and it's interesting, isn't it, that middle managers seem to struggle in this way, because certainly a lot of doctors in the middle stage of their career, and particularly I have to say doctors at the early stage of their career, really engage with this stuff in the most enthusiastic of ways, because they come into organizations, they can see all the problems around them, they often move to new organizations fairly frequently, so they're constantly seeing the challenges, they're seeing how organizations could learn from each other, and they're really engaged and enthused by it. So I think you're right that the problem with middle managers is what their principal driver is. And I don't think we'll embed improvement science unless we address those motivations and those drivers for change. And it isn't just about middle managers, actually it's about clinicians, it's about academics as well. If you're an academic, getting a paper like that into the New England Journal of Medicine is truly brilliant, but it doesn't happen that often. The majority of improvement scientists find it quite difficult to publish their work in high-quality academic journals, and that's a big problem when your currency as an academic is about high-quality publications. Okay. So I think we really do need to address what the drivers and success criteria are for improvement science, so they might be just slightly different from conventional drivers.
My name's Sally, I'm from the James Lind Alliance, and we generate and prioritise research questions about the effects of treatments in partnerships of clinicians, patients and researchers. My question is, we recently did a survey in type 1 diabetes, and we had a question in from a patient which read as follows: what could professionals learn about effective self-care in type 1 diabetes from the stories of people who live with type 1 diabetes successfully? So my question is, what can quality improvement science learn from patient experience?
Yeah, it's a great question. And for improvement science, as for improvement practice, the patient, the client, the user, the customer must always be absolutely at the center. So when I talk about improvement science being a partnership between academics and people working the front line, I'm including the users of the service in that. So I think they can bring an enormous amount. Patients were involved in that Michigan study. They were very involved in another study that was published just last week in The Lancet, which is another superb example of improvement science, a study that we actually funded as a health foundation, which is about identifying and referring victims of domestic violence in primary care in 2 cities in Bristol. Patients users very involved in the whole design and the conduct of that study. So, so central.
Okay. Next question over there, please.
Oh, hi. My name is Ali. I'm a DPhil student at Oxford. It's just regarding your point about bringing multiple interventions together as they would be more effective than single interventions. I just want to see if you have any solutions in terms of the methodological challenges this could have in terms of research with the rigidity of randomized controlled trials and the defined outcome criteria, etc.
Yeah. There are challenges. They're not insurmountable challenges. And one of the another defining characteristic of improvement science is the fact that rigorous methods can and should be used, but they can be used in quite pragmatic ways. And we're seeing a range of ways in which randomized controlled trials can be used without them being so pure that the results are therefore meaningless. So the study that I've just mentioned, based on looking at improving the referral rate for domestic violence, was actually a randomized controlled trial. It was a cluster randomized controlled trial. So there are ways of using that. But, and this is an important but, there are many ways of gaining knowledge. Science is about gaining knowledge which is general knowledge, general truths in systematic, rigorous ways through observation or experimentation. It doesn't require just randomized controlled trials. And some of the best insights that you get from quality improvement work can be anthropological work, can be narrative work, some really rigorous and sophisticated methods, but not necessarily the ones that we're conventionally brought up to as clinical scientists.
Hello, my question sort of goes back to what this gentleman was saying about middle managers and your mentioning of a conducive environment. I think very often people within the healthcare system feel blamed or chastised or somehow at fault, the wrong end of the media stories, and that happens a lot to health services managers. It happens to healthcare workers as well. GPs, although we manage to maintain our 90% ratings with patients, are often the butt of stories in the Daily Mail and elsewhere for failing to do this, that and the other. So although I agree that patient autonomy and patient involvement is extremely important. So is staff autonomy. And what is it that we need to do to make our staff feel valued, give them some control over their lives?
Yeah. It's a question that takes us beyond the boundaries of improvement science, isn't it? But it's such a fundamentally important question, and never more so at the moment than when we're going through mid-staffs. It's going to be really interesting to see what comes out of the Francis inquiry around mid-staffs, where a lot of good clinicians could see terrible things happening around them. Certainly a lot of the patients could see terrible things happening around them, and either they didn't stand up and say anything, or they stood up and were ignored. And there's no doubt that the blame culture was very strong in that institution. So I think understanding, if I were to bring a scientific light to that, understanding what blame culture means, how it develops, what methods there are of eradicating it or reducing it, because there are organisations that are genuine learning organisations that seem not to have the blame culture that's so prevalent in a lot of NHS institutions in the UK. So I think improvement science would shed light on what we mean by blame culture and what we could do about reducing it. Does that answer your question? Kind of.
Yeah, it's an interesting one. I think that it really goes to the limitations, I guess, or the scope of improvement science. There's black swans. I mean, if we think about what happened in Staffordshire in terms of a black swan, which is, we've got a measurement set, which is what we're using in the quality improvement paradigm. So we've got our data. This is what we're measuring, but there are limitations to that, and so there are areas that are unmeasured. And we are taking some comfort, presumably, that what we're focusing on is important enough that we can only need to worry about that, perhaps.
Yeah,
that's a factor, isn't it? Yeah. Any more questions at all? Okay. Where do you think the next step is in terms of the development of measurement science? And there's one aspect I was thinking, I've got to ask you this, and I've got a nice background, so I'm going to ask you about the cost effectiveness of quality improvement interventions. Are they cost effective? Are they value for money? And if you're going to have to put lots of them together into getting an effect, it's going to be more expensive. And secondly, in terms of development we've got to metrics, we're starting to use metrics more widely. Are we likely to see appropriateness methods or other tools like that sort of come into play in the future?
Yeah. Okay. So cost effectiveness of improvement methods is a major challenge for the improvement science movement, because I think a lot of claims, sometimes rather wild claims, are made on behalf of improvement methods that they'll dramatically save costs. Indeed, I think probably a lot of the Department of Health's QUIP programme is based on that premise. The evidence is that they have the potential to do so, but it's very difficult to deliver in practice. And as a foundation, we funded a review by John Obertveit, one of the leading health service researchers in this field from the Karolinska in Sweden, who looked at the cost effectiveness of improvement interventions. And his conclusion certainly was that, yes, they can be, but in practice, the ability to roll out change at scale, the kind of changes that you see in small little projects at scale, is nowhere close to what is required in order to save to address the Nicholson challenge, the £20 billion that needs to be saved from the NHS between now and 2014. So cost effectiveness is a big question, and I don't think we should be doing any quality improvement project in the current environment that doesn't have a cost effectiveness analysis as part of that
That's interesting to hear.
process. What are the big challenges? I think there's almost kind of parallel challenges. The challenge is, how do you get improvers, clinicians and managers and patients working the front line to really engage with the science of improvement, to get them out of the slightly evangelical territory or the completely disinterested territory that they're in at the moment. So there's a question there which I think is a challenge. How do you get them engaged with a more rigorous approach towards improvement? My experience of talking to the majority of improvers is actually they're very willing to do it when you start having these kind of conversations with them. The other question I think is a more challenging one, which is how do you get top researchers into this field of improvement science? And maybe Peter can answer this question for us. I don't know, but there are some great health service researchers out there who kind of dabble in improvement science, but then quickly retreat back into their laboratories or darkened offices. And this comes back to my point that we really need to align the incentives and the success criteria for these people far more effectively than we have at the moment. And I'm starting to see universities doing that. Within London, 3 big academic health science centres, major biomedical places who are doing truly superb biomedical research, and they're just starting to understand that there's another agenda out there, and they're just starting to engage with it. So I think the door is just a little bit open.
Okay. I'm going to ask one very last question, because you guys are in the middle of what would have been your refreshment break. You've still got 15 minutes left, but this is an amazing opportunity to put some questions to you on issues which are going to be at the forefront of policy for the next few years. Is there any thinking from the Health Foundation around whether we should be spending the same amount of money on patient safety to prevent adverse events, prevent unnecessary deaths, as we should be to save lives through effective treatments? Or should we be spending more? Is there a difference in the value for money in both of those different strategies? Because a trade-off has to be made, presumably, with a fixed budget around what you can do.
I don't know the answer to the question. I think probably that the money that could be saved from avoiding the harm that we cause in the health service is probably amongst the easiest money to take out of the health service. But I think it's probably a relatively small proportion in comparison with the ineffective major challenges around clinical effectiveness that we haven't addressed. I think there's a bigger gap there and a potential for more savings.